There we go. Now I'm recording. Y'all will have to wave at me as you pass by next semester going to 270. I think it's 230 that's next door to me. As y'all are going to 230, you'll have to wave as you keep walking by. Yeah, absolutely. All right, so cardiac defects. So the big ones I want y'all to focus on. I know in the recorded lecture, it talked about several that I kind of glossed over just to mention in case you saw them, but I really don't want you to focus on things like hypoplastic left heart, truncus arteriosus, transposition of the great vessels. I'm trying to think of some of those that we don't really focus on. The ones I want you to focus on are the ones that were listed on that content worksheet, especially the VSD, ASD, the tetralogy of Fallot, and the coarctation of the aorta. Those are your big ones I want you to focus on and know what those are. So there's one in each category. We categorize these congenital heart defects into basically the big effect that they have: increased pulmonary blood flow, decreased pulmonary blood flow, or constrictive. Or sometimes you'll see it called either constrictive or restrictive, depending on the text. They mean the same thing. They'll just use the words interchangeably. There's no difference in the two. So if you see someplace call it constrictive and you see somewhere else call it restrictive, that's okay. It's just a different term that they use. Sorry. So when we're talking about increased pulmonary blood flow, what this means is there's increased blood flow going through the pulmonary system. So this blood is getting recirculated. You know what, let me pull up whiteboard. I know there's a whiteboard. I've used it before. Where is it? Thought there was. Okay. Hold on. Share a window. Share more. There we go. That's what I want. Whiteboard. I knew it was here. There we go. So when we're talking about increased pulmonary flow, oh, why don't you draw for me? Increased. So if you have your 4 chambers of your heart, and yes, I know this is not anatomically correct. Your right and left. If you have a hole, and a lot of times, think of your increased pulmonary flow, think of holes. There's a hole all by itself. So for instance, a VSD, there's a hole here.
Mrs. Martinez,
are you drawing something?
because
I can't see anything.
See it?
No.
What? That's annoying. It tells me it's sharing with you. Hold up. I might have to do this a different way. Close. X. So you saw it, Jamaica?
Yeah, I can see it.
That's weird. Are the rest of you on your phones or your laptops? Oh, well, then I didn't explain it. That's odd. Let's try it one more time. If this doesn't work, I'll pull it like... Huh.
I get a message saying the content being shared is currently not supported.
Oh, that's weird. It's just the whiteboard through the program. You know what I'm going to do? I'm going to pull up the Paint program and share that app. I've done it that way, and that's always worked out. So I will say I've never used the Skype's whiteboard. I just knew where to find it. Go to Paint. Glad y'all told me. All right. Please hold for technical difficulties. here. More. Okay, this is going to aggravate me. I know I can do it. Let me X that off. I'll try to share my desktop. It usually acts up. Let's see if it's going to act up this time. Oh, maybe it didn't. Do y'all see my screen? Like that shows Skype with y'all's little blocks across it? No? Natalie, you do. You see it, Trisha? Oh, you see it now. Okay. All right. I'm going to switch over. Tell me, because I won't be on with the Skype window, so I won't see chat. Speak up if y'all don't see me when I'm on the paint one, when I switch over to paint. All right. Can y'all still see me?
Yes, I can see it.
Yes.
Perfect. All right. So let's try it this way. So when we have increased pulmonary flow, so increased. So pretend this is a heart, not an anatomically correct heart, but we got our 4 chambers. And that's our right side, and that's our left side. So when we have increased pulmonary flow defects, I want you to think of holes. PDAs, VSDs, ASDs, they're all a hole. They're an opening that's not supposed to be there. So for example, when you have a VSD, a ventricular septal defect, you got a hole right here where it's open. So it's allowing blood to go back and forth. The thing is with your VSD and your ASD, the pressure on the left side of your heart is a little bit higher. So each time it squeezes, instead of it just going back and forth randomly, because the pressure is higher, and as you learn in physics, things go from an area of higher pressure to an area of lower pressure, the blood's going to go this way. So some of it will go out the aorta. So under normal circumstances, you have your aorta over here, and some of the blood is going out that way. But not all of it, because there's an opening, so it's just going to kind of go wherever the opening is. So some of it's still going this way, and it's getting recirculated, going back up to the lungs, getting reoxygenated, or just passing through if it's fully saturated, and coming back down to the left, again, over and over. So some of it is going out, but some of it is getting recirculated. So you don't see like cyanosis with this, because the blood is getting oxygenated. It's not over-oxygenated. But the problem we have with this is if it continues, especially if you have a large VSD, it's a lot of blood that the heart is having to extra process. Basically, the heart's now having to work overtime, and the heart's getting tired. So it can potentially lead to heart failure because of the extra work that's being put on it. So your increased cardiac defects, or increased pulmonary flow cardiac defects, I want you to think of holes by themselves. There's nothing else with it except one hole. So when we talk about decreased, the big decreased one that we talk about is tetralogy of Fallot. Now, tetralogy of Fallot, one of the defects, it's 4 defects, that's why they call it tetralogy. One of them is a VSD, and by itself it's increased. But then when you add the other complications with it, that's what decreases the flow. So let's take our heart, and I'm going to separate it this time and put the lungs in the middle. So you have your right atria, left atria, right ventricle, left ventricle. And then, yes, I know your lungs are not in the center of your heart, but just for pictorial purposes here, we're going to put our lungs right here. You know LU means lungs. And then we have here, going from, I should have left an opening, we have our pulmonary artery. coming out here. And then we have our aorta coming out here. Kind of. Ish. I will never teach art, I promise. So, that's our normal function. What we're looking at is abnormal, and you could use VERT, PROV that help you remember the 4 difficulties or abnormalities. And they all come together to create a situation where you have unoxygenated blood going out to systemic circulation. So the first problem we have, the V stands for VSD, ventricular septal defect. So there's a hole right here connecting these two. So in and of itself, you would have increased flow. But the reason this is a problem is with that VSD, that ventricular septal defect, we also have something called an overriding aorta, which is instead of the aorta coming out here like it's supposed to, it comes out, and yes, I know it's not that big, but we have it coming out right over where that VSD is. So instead of just pulling blood from the left ventricle like you would expect, it's now also pulling blood from the right ventricle that hasn't even been through the pulmonary system yet. So that's where some of your unoxygenated blood goes to. What further makes this worse to make that unoxygenated blood go out is, we're going to skip R, go to P. P is pulmonary stenosis. Instead of this pulmonary artery being open, it's narrowed, which means that's more pressure that this right ventricle is having to push against to try and get the blood into the lungs. So that further increases blood wanting to go this way because there's less resistance. Because of that pulmonary stenosis, whoops, you weren't supposed to draw, whoops, it causes right ventricular hypertrophy. Just like when you have a patient who has hypertension, they get ventricular hypertrophy because of that muscle having to work so hard. So you get thickening of that muscle wall, the R, right ventricular hypertrophy, which means it can't fill as much. So you have decreased filling, resulting in not as good of output. So the reason, and this explains why you see the symptoms you do in patients. At rest, a lot of times patients with tetralogy of Fallot, especially in the beginning, now without treatment, it will progress to where it causes more significant cyanosis and death. But in the beginning, at rest, when they're just sleeping, they look normal. They appear normal. They're not cyanotic. They're fine. But anytime they have activity, whether it be sleeping, listen to me, eating, crying, being awake, different things, your body needs more cardiac output when you have activities. So it's going to pull from the path of least resistance. So it's not only going to be pulling from here, but it's going to pull more from that right ventricle as well. It's just going to be greedy and pull as much as it can from everywhere it can from both sides. And that's where you get the TET spells, or the hypercyanotic episodes, where they turn blue, especially with activities. So that's your increased flow, where it's just basically going through the heart over and over and over again. Some of it's coming out, but some of it's getting recirculated. With your decreased pulmonary flow, this is where not all of it is actually going to the lungs. Some of it is bypassing the lungs and just leaving and going back out into the circulation without getting oxygenated. Now is there a way to clear this? No, that's just undo. Let's paint. You know what? No, that works. So when we're talking about our restrictive disorders or obstructive, depending on how you see it, this is where there's some kind of obstruction or restriction, so blood flow is not going the way you want it to. It's having to push against resistance. So in this case, our problem is not in the heart. So we have our heart. I'm just going to leave the opening right there. No, I won't. So we have our heart, and we have our aorta, and we have our major vessels here that branch off into our head and neck and upper extremities. So right here, it's getting that blood flow. Our problem is below that, it's coarctated, it's constricted, it's stenosed. So the coarctation of the aorta, because of this increased pressure right there, blood is getting backed up into here. So you'll have the increased pressure in the upper half of the body. The blood pressures will be higher in the upper extremities. Some of the symptoms, you can get nosebleeds, things like that. That was mentioned during the day class. Headaches if they're older. Those are some of the symptoms. Whereas down below, it's having decreased flow. So your blood pressures will be lower in the legs. You may have cool to touch skin, decreased pulses because there's less blood flow. And it, depending on the severity, it can compromise perfusion. Is there anything I left out?
No, those pictures helped.
Yay, good. I'm glad.
As opposed to trying to explain it in the PowerPoint. And I'm like, what is she talking about? Where? Like, I was a little confused.
And that is one thing I sorely miss about being in the classroom, is having a board that I can draw and write on. I'm sorry for my poorly drawn digital images. It's much more difficult to try and do that with a mouse than with a marker. Yes, she's got a good video too. Absolutely. I love Registered Nurse RN. She's got some really great videos that they're short, but they outline, they're very specific things. It's not where it's like an entire hour-long lecture. It's just a short snippets of information. Close that. And it's much easier to absorb information when you're looking at little chunks. I love Registered Nurse RN. Something I was going to say about her. Can't remember what. The only thing that people have issue, and I don't want to say issues, if you look at her dosage calculation examples, she likes dimensional analysis. If you love dimensional analysis, she's your girl. Watch her videos. If you hate dimensional analysis, that's the way she does all of hers, so those might not be helpful. But she does a really great job of laying things out. That's the only thing I've really seen that she's specific on. She's got some good videos, and she's got tons of them. Kathy Parks, I know her videos are not all out yet because I'm sure y'all know she had to take down a lot of her videos because hers were ATI specific and she was not employed by ATI. But she's changing hers up to be topic related and as opposed to ATI related. So she's building her library. She's putting out some new cards too. Nursing.com is I know I've mentioned that one before. They have, you don't have to get a membership to nursing.com. They have several freebie resources as well. Now, to get the full content, they do have a membership, but they have like a freebie Friday where they'll send you a little cheat sheet of something every Friday to your email. I know cardiac is something that people struggle with when it comes to cardiac defects because you're used to adults where it's like heart failure and stuff like this, and this is more anatomical. Now, when we're talking about the problems like heart failure, for example. I mentioned how some of these can result in heart failure. That's no different than adults. The symptoms you learn as adult symptoms of heart failure, that doesn't change. Where they can get the sweating and fatigue and edema and all that stuff, that's no different. Correct. Yes, these are all things that they're born with. They're anatomical defects they're born with. These don't happen. They're not acquired. They don't happen later on. The biggest acquired congenital defect we probably think of when we think of peds is mitral valve prolapse that you get from rheumatic fever, which we don't really talk about too in detail. More so if you get rheumatic fever too, they take aspirin for that to decrease the cardiac workload, to decrease their risk of getting cardiac complications from it. But we don't really focus on the actual defects that much. But yes, these are all congenital. And as far as cardiac, that's really the only defects as far as anatomical defects you need to worry about is the ones on that worksheet. All the other content, I'll tell you, this is not all inclusive. There'll be other stuff, but this, you don't have to worry about the more complicated ones. In case you see the words, though, because you will see them in your ATI book and stuff, it's good for you to recognize that you've seen them before. But
So you're saying we don't need to know them for your test, but possibly for ATI, the proctor?
For
the defects.
These defects, yes, you need to know these.
Right, but as for the other ones, would we need to know those for ATI?
No, I wouldn't focus on them.
Okay, just checking.
Yeah, I would not focus on them. They are not really defects that are focused on for beginner level nurses that the NCLEX is looking at. What questions do y'all have? I know today was a lot of content, or will be a lot of content if you're in my evening class. I cannot say this enough. Make sure you're going back and reviewing old content. Remember, your final's cumulative. Even if you just spend an hour or two a week just reviewing the old information, reviewing your old exam reports and rationales and all that stuff. Is it that y'all know this information so well, or y'all just don't even know what to ask?
the second thing you said.
I know. Hopefully y'all have at least listened to the lectures, and I know that you're going to have to probably listen to them a few times to get everything. But it's make sure you're listening to them and you're taking notes, and the more you can reiterate the information to yourself, the better you're going to obtain that knowledge, or retain that knowledge is what I meant. Well, we only have one more week, so we got to get it in quick. Got to make sure you're prepared for your proctored and for your NCLEX. Be here before you know it. And I figured y'all would opt to cover all this in one day instead of having class after the exam last week. Because most of y'all are usually mush after an exam. Oops, I don't want you. Yeah, absolutely. Kawasaki's disease. So Kawasaki's is a vasculature inflammatory process, basically. It's a reaction often to some other type of illness. I don't know if y'all remember hearing about a couple months ago where they said children who developed COVID were developing Kawasaki's disease. So typically Kawasaki's, they start looking at after 5 days of symptoms. Prior to that, they'll look at more viral illnesses. Think of red. Think of a red motorcycle when you think of Kawasaki's disease. So lots of red symptoms. So, and it's because of that vascular inflammation that's causing it. So red bloodshot eyes. They'll have the red mucous membranes. Their lips will often be a bright red. Their tongue, they'll have something called strawberry tongue, where it's a red in color with darker red dots on it. They'll have red. The palmar and plantar surfaces of their hands and feet will be red, and then they'll start peeling after a few days. Rash, high fever that's often uncontrollable with antipyretics. Those are probably the biggest symptoms. The biggest reason that Kawasaki's is concerning is because it can cause cardiac problems like myocarditis, and it can cause aneurysms because of the inflammatory process going on in the vasculature. It causes weakening of the walls, And when that weakening happens, if there's a lot of pressure being put against those walls, it can cause them to pouch out, which is an aneurysm. And aneurysms, we worry about rupturing, of course. So we want to prevent those aneurysms from happening. So they'll be admitted for IV immune globulin, which will decrease that inflammatory response. And we also give them aspirin, which will help decrease the pressure on the walls, decrease the workload of the heart, hopefully preventing those complications from happening. I think I included everything. Think red. And this is one of those few things that we actually give aspirin for. Absolutely. I sure can. You know what? I got a little video I'll show you, in fact. So an air enema is an enema that uses air. Not to be so direct, but and when you push that air up in there, it's almost like popping it out. Let me show you. And with an intussusception, that's exactly what we want to do. We want to push that piece that's telescoped into the other bowel. We want to push that back out. And ideally, that's what's going to happen when you do an air enema. But let me show it to you. Where are you? First bones. Haha, there we are. I'm going to turn the volume off because the little kid is screaming in the background and it's a little distracting. Pull the video up. All right, so this is an X-ray version that you'll see. And you'll be able to see it. This is under fluoroscopy. You see the contrast dye go up. You see it building, it's building. And then you see it get reduced. And you can kind of see that bowel pull out from inside of itself. And then it continues. It released that blockage, basically. Does that make any more sense, or was that not what you were looking for?
Not really. Like, I don't understand, like, how are they forcing air in there, I guess, maybe is my question.
Oh, it's a special machine. So it just like when you take a Fleet's enema, you have a bottle of water and you stick the tip in their rectum and you squeeze the bottle that pushes the water. They have a machine that squeezes the air and pushes the air up through their rectum into their bowel.
Okay. I think I get it now. Does that give them, like, gas afterwards?
Oh, yeah,
like, are
absolutely.
Okay. There's an awful lot of flatulence after that.
Yeah, they are definitely going to be gassy afterwards because it's all that, what goes up must come down, and they're going to have to get all that back out. So it's a machine. It kind of pushes that air up pushes it, pops that bowel back out, and then, yeah, the air will just come back out on its own. Most of the time it works. Every now and then you gotta have surgery, but, oh, you're welcome. It happens more often than you'd think. I've only seen a couple of cases, but sometimes they self-resolve without even needing it. Like the one I told Joe about, the kid I had when I was a nursing student. Just went away while we were waiting for the team to get there. And the way you would know it has resolved, one, they stop crying usually because that pain, what's causing their pain is the blood flow getting cut off, that inflammation, that tightening around it, the blood flow is getting cut off, tissue's dying, it's causing a lot of pain. Once that pressure is released, they're not going to have that pain anymore because the tissue is now able to breathe. So they'll stop crying, they won't be upset anymore, and they'll have a normal stool. So once they have a normal soft brown stool, great, go home, bye-bye. One thing that wasn't on the worksheet, celiac disease, they have to avoid what? Y'all probably know this one well.
Gluten.
Gluten.
Yep. Gluten, your wheat, barley, rye. TE fistula, tracheoesophageal fistulas, coughing, choking, cyanosis. Your symptoms. Hey Jennifer, did you know your mic is on? I didn't know if you knew.
No, I didn't. Sorry.
That's okay. I didn't know if you knew or not. Appendicitis, when would you be concerned? If they say what? When would you be concerned with appendicitis? More concerned, I should say.
Is it abdominal distension?
Yeah, when it stops hurting. Nope, not abdominal distension. When it stops hurting, when they say, I feel better, or I'm hungry, or my stomach doesn't hurt anymore. That's not a good thing in this case, because that's probably an indicator that they ruptured. As that pressure gets released, their stomach will stop hurting. Shortly, you're going to find out that they're going to start showing signs of sepsis, though, so the feeling better will be short-lived. There's a big difference in caring for a patient with a routine appendectomy and a ruptured appendectomy. Routine appendectomy is an overnight stay in the hospital. Ruptured appendectomy is usually several days to sometimes weeks, depending on how severe it was with IV antibiotics. Lots of post-op pain. Come on, eyes drive me crazy. I feel pretty confident y'all know urinary tract infections by now, I'm sure. Oh, I'm burning. Oh, one thing I don't know if I said this in the recorded lecture or not. When you're looking at vomiting versus diarrhea, when it comes to acidosis and alkalosis, alkalosis is related to vomiting because of the loss of stomach acid, versus diarrhea causes acidosis. There's an easier way to remember that. Acidosis is from the ass. Can't remember if I actually put that in there or not. It's how I remember it. Yes, exactly. That's how I remember stable vagal, unstable cable. If those of you don't know what that means, you will learn about that in med-surg too, probably. With your, oh, wait a minute, I talked about that with SVT, didn't I? You'll learn about that even more with in med-surg. You really go over arrhythmias in med-surg too. In fact, that's what you start with. So just an idea of what to work on your, week break. We don't really see a lot of arrhythmias in pediatrics. SVT is probably the biggest one. So if you don't like cardiac and you don't like drugs, peds is a pretty good place to go. We have less drugs and less cardiac. But then, we do have all that growth and development stuff. There we go. Do y'all have any questions? Oh, eyeballs dropping. anything I can answer? All right, guys, if y'all don't have any questions for me, I don't want to hold y'all up. I'll let you go unless y'all have something you wanted to ask me, but I don't want you to have to sit here and feel like you have to stay. By all means, you can always email me, and I'm here if you think of something in a few minutes and you're like, wait, come back. Let me know. Okay? Otherwise, I will see y'all either tonight or next week. Y'all enjoy, and I will see y'all later.